expectation and reality. So the whole idea of step care actually was inspired for me and, in the field by the work of Andrew Chanin, who said that BPD should be just like any other illness that has stages for which you apply different interventions. So for cancer, you determine what the treatment is by the stage and the advancement of the illness. So you'll do the same for BPD. And I've revised this kind of model to look at the different kinds of categories we think about in terms of BPD. So when someone's not meeting full criteria and they're preclinical or adolescent, you really just need to provide some psychoeducation and support for families. Maybe you'll do some psychoeducational groups. And if they go on to have more severe symptoms like self-harm specifically, which is quite common among adolescents, you will do some GPM and case management and support their families. Families don't know what to do with self-harm. Most physicians are shocked by self-harm. So giving them some information so that they can cope and support their child in a way that will help them manage optimally is important. And you really don't need more formal treatment until they enter this sustained moderate or severe period. Now, the last part of this model is those frequent flyers, the people who are always in the emergency room or always in the hospital. Actually, that's where you do less treatment. You just provide supportive care. It's almost like social assistance. For people who have a disability related to BPD, you don't give those people this intensive change-oriented treatment. They probably already had it, and they're doing the best they can, and they just need some support to live and survive. So how do we know GPM works? Actually, this is a discovery by accident. When DBT was studied by an investigator outside of Marshall Linehan's lab in a large, rigorous, randomized controlled trial, the key investigator, Shelley McMain, wanted to have a decent comparison treatment. Because if you compare 5 hours of treatment, like DBT, to terrible treatment, as usual, who's going to win? Probably DBT. But if you compare DBT to a treatment that's less intensive, informed, predictable, and applied by people who like to work with patients with BPD and know something about it, actually the differences aren't that significant. And that was what was found in this trial. It's one of the largest trials done to date. And I think that Shelley McMain was rather brave in publishing this. Because what they found was that both treatments decreased hospitalization, self-harm, and depression and anxiety across different outcomes. They were statistically comparable. But because GPM pays attention to psychiatric comorbidities and DBT doesn't, GPM did better at retaining patients with comorbidities than DBT. So what's the structure of GPM? It's once weekly if useful, and you use the equipment you have. If you have medications or need them, you can use them in a reasonable way. If there's family interventions like NEA BPD Family Connections, use it. Anything works. We're flexible and practical. So the specific features of GPM include diagnostic disclosure. This is a right that patients have. It's considered malpractice if you don't tell a patient that they have cancer. And the same should be true of BPD because it's fatal in some cases, disabling, but treatable, especially if you intervene early. You want to teach people that they have an interpersonal hypersensitivity problem that explains all their symptoms. Just like when you explain to people that have diabetes, they have an insulin insufficiency. So that causes them all the visible, observable features of diabetes. And that will help them to change and modify their behavior to optimize their health and minimize their symptoms. You want to not just make therapy the precious zone of focus, because people with BPD are already interpersonally sensitive. So they're easily attached and prone to exclusive relationships, and they will have this point of view that they need that person to survive. But what GPM does is try to reverse this and teach people, no, actually, I'm not doing a good job for you unless you learn how to live your life as it is outside of the office. My job is to teach you the lessons and instill the confidence in you to take on usual life challenges with your interpersonal hypersensitivity. And this is founded in psychoeducation about the causes, the natural course, and the social difficulties that people with BPD will have. And the treatment is evaluated not by how much the person likes you or understands you, but by progress. Any medical intervention should be evaluated based on how effective it is at reducing symptoms and increasing functioning. And the good news is GPM is adaptable no matter what your orientation is. It has psychodynamic ideas. John Gunderson was a psychoanalyst by training, but he was also a scientist and a skeptic. And he really embraced the practicality of behavioral therapies that focused on changing how a person acts, not just changing their understanding of themselves. And most importantly, it really focused on the involvement of families. They are the family the patient has. Doctors or clinicians or therapists come and go. So you want to instill some useful skills and knowledge for the family or the support system as they exist. So the adaptations of adult GPM include the inclusion of patients who are beginning to have BPD. So they may be sub-threshold, the translation of material in a way that these patients can relate to and understand it, participations of families as far as they're willing. Your job as a clinician is to just offer it and making recommendations. Their job is to decide what to do with it. The treatment length should be shortened because you want to get the young person back to the environment that they have to grow up in. And you also make developmental considerations like identity functions, autonomy issues, and the kind of concerns of getting along with their peers. So teens are so preoccupied with all this, you want to take advantage of that and tell them that the treatment you have to offer will make them better at relating to people. So then, where does this leave you with all the other treatments? GPM represents what all treaters should know about BPD, no matter how specialized you get. It's like laundry detergent. They all say they do different things, but they all clean the laundry, right? So it's good enough for most patients, and those who need or want more can get these other treatments if they're available. So just quickly, I'm just going to go on to the core idea, which is interpersonal hypersensitivity. So every treatment that has been built for BPD that's been effective has a core formulation of what BPD is about. And we know that during our life course, relationships cause us a lot of grief, right? If you ever have a conflict with someone, it stays on your mind more than you want it to. And it produces the emotions that we then associate with emotional dysregulation. So when these things happen, for all of us, we become very volatile, and it's like we're on a roller coaster. But for those with BPD, it's more aggravated and felt more intensely. So do you know this movie, Mean Girls? Yeah. Okay, good. It's a universal phenomenon, Mean Girls. So in the transition to adolescence, there is this transition to having more responsibility and demand. When you're before adolescence, kids are like kind of coddled, right? Everyone adapts to them. Everyone looks after them. Everyone's nice to them, usually. But in your teen years, all of a sudden, your coaches are yelling at you. Your teachers want more complicated work. You have to compete with others more actively, and the social world is chaotic. You don't know who's nice, who's not nice, what's going to happen 1 minute or the next minute. And then you have your parents who you become a little bit disillusioned with. You don't like them as much as you used to. And the job of adolescence is to be able to kind of internalize our relationships with others so that we can kind of separate and individuate. So interpersonal relationships are a source of self. They're both within us. Our self-experience and sense of self comes from our interactions with others. When you become a doctor, you only feel like a doctor because people are like, doctor, tell me what to do. Because there's a social interaction in which your identity is formed. And this is defined by the type of relationship. So as you grow up and you become a doctor and a parent and a partner and, a parent and a grandparent and an aunt, all these features of oneself become your identity. But in adolescence, people are troubled by the volatility of their own brains. So this is a comic of the anatomy of the teen brain. And in reality, what really happens in the teen brain is that there's a lot of pruning and restructuring. And people are impulsive at this period because they have more freedom to act on their own and make their own decisions. But the kind of connectivity between the thinking part of the brain and the acting part of the brain are just kind of starting to remodel. So actually, my friend who's an expert in the teen brain and substance use said that, in adults, when you're testing their sobriety, you do this kind of thing. Teens can do that because their kind of physical, kind of anatomical brain is more tightly wired. But if you ask them to do math, they can't do it. So if you are trying to tell if your teen is intoxicated, you ask them to do math, not physical acts. So what you do with the teen is you understand that they're moving from a dependency on adults to independence with these very treacherous peers. So there's a bridge, and successful development really relies on being able to kind of modulate your way back and forth. You go back to your parents when you need them, but then you go out on your own when that's called for. And so for the adolescents, they're going to have a lot of dilemmas about, do I rely on adults or do I bond with my peers? But for those who have BPD, this is more difficult. It's like that bridge is on fire. And they run to being more dependent or more independent. And that's a real dilemma for everyone involved. So, how do we know scientifically this to be true? We also know that BPD is actually heritable. The degree of heritability is quite high. It's higher than depression, but lower than schizophrenia and bipolar disorder. So about half of the variance of the risk to become borderline comes from genetics. We also know that interpersonal features are what distinguishes those with BPD most from those who have other disorders. The core diagnostic features are a desire for exclusive relationships. So this is something that Catherine Winsper found in her longitudinal study in the UK, is that those who had exclusive relationships, like one best friend at a time, were more likely to develop BPD. Girls tend to not be as sure of themselves or have some confidence or clarity about who they are. They may have chronic feelings of emptiness, inappropriate, intense anger, more so than what's usual for teens, and in boys, more paranoid ideation. And boys are more aggressive in general, so maybe they have reason to be paranoid if you see the play of boys versus the play of girls in a typical way, but that's not always kind of just following stereotypes. So the interpersonal events we know trigger the core features of BPD. You'll see them here. Also, we know that childhood disorganized attachment, separation problems, and attachment tendencies tend to predict adolescent BPD. And the genetic vulnerabilities that make them more stress sensitive and more disturbed in their bonding tendencies are disturbed in BPD. So this is really the end here, is that the coherence of all the symptoms of BPD really has to do with how related you are to others, or how connected you are to others. So everybody knows who this is, Taylor Swift? Okay. More people know Taylor Swift than John Gunderson. So this is a music video that depicts how much Taylor Swift relates to having borderline personality disorder, because there is a period where she's living her dream, she's very happy, but something threatens her and she becomes more angry, and then she withdraws because of the intensity, and then there's a sense of despair and meaninglessness. And that is really the kind of interpersonal oscillation that occurs that makes the symptoms of BPD change. So what we say is, for adolescents, we put this in terms of rejection sensitivity, actual rejection, and being socially disconnected. Because actually what happens is they fear being rejected, and then they act in these hypervigilant ways. And then when they think they're being rejected, they act in a way that pushes other people away. And when they're without others, because they're so dependent, they feel completely uncontained and lost. And that's why they become impulsive, self-destructive, and sometimes suicidal. And the truth is that if you actually have people start to show concern because they're so self-destructive, then they actually feel more connected, and then they'll be okay. But this isn't a treatment plan, because this just creates instability. What we're saying in GPM is that you want to lean in when they're angry, okay? Because that's where you work out the problem and you try to understand them, then react to them. I'm going to skip this. So there's a lot of difficulties adolescents uniquely have, especially in the digital age, where there's more modes of being isolated, criticized, and rejected. But the implications of all of this are that these interpersonal sensitivities will define the features you see in these patients. And so the emotional and behavioral discontrol or dysregulation is secondary to how stable their relationships are. You want to proactively connect symptoms to something that happened for them. Don't wait for them to tell you. And then their action or inaction. The action or inaction of other people will trigger their sudden and unexpected responses that reflect these oscillation and symptom states. So we tell people what this means is that you were born with hypersensitivities that would make it difficult for others to respond in ways that you find helpful.